Welcome, everyone. Thank you for joining us again for our weekly Zoom meeting for the New Hampshire COVID-19 Vaccine Alliance. My name is Jim Potter. I am the Executive Vice President of the New Hampshire Medical Society. And we formed this particular alliance was developed off of our Mask Up New Hampshire project that we started this summer in collaboration with the New Hampshire Hospital Association and the Business and Industry Association across the state here in New Hampshire. Just a quick summary for those who are new to this call. The mission is to convene like-minded stakeholders across the state to promote vaccine confidence, support accurate and consistent vaccine messaging, and to foster coordination of the vaccines allocation. Our goals are to promote public buy-in for the vaccines to increase immunization rates. And secondly, probably most importantly, is to act as a multiplier force to support the communication allocation plans for the New Hampshire Bureau of Infectious Disease Control and Immunization Program. Fourth, our goal is to counter misinformation on the COVID vaccines, particularly as we move into the public rollout of the vaccine. And then fourth is to foster use of the New Hampshire's immunization information system. And if you're not familiar with that, that is the name for essentially our New Hampshire Vaccine Registry. We are the last state in the nation to have such a registry. This system does a little bit more than just being an actual registry. It is being stood up right now. We'll probably discuss that more in these upcoming meetings as we move forward. Next slide, please. So if you weren't able to join us last week, the takeaway from our Alliance meeting was, one, if you are in the most risk 1A group, you should instruct you and your staffs to pre-register at the link that's there, and we'll post it in the chat area so that you can go directly there if you don't already have it. I'll just mention all this information that we're kind of conveying can be found at the department's COVID-19 vaccine information site. And that URL is at the bottom, but it is a sub-tab of the COVID site for New Hampshire. So you should be able to find it there. Secondly, those who are not an employee of a hospital, or you've been told that you're going to get your vaccine there, then you should schedule your vaccines at one of the current 13 fixed sites by the states. If you register for one of the hospitals, you'll likely be turned down and just delay the process. So again, when you get that scheduling email, please choose one of the state's fixed sites. This information is in HON 32. That's not quite up on the site, but hopefully that'll be there. We distributed it, and we can make that available. But it updates the CDC guidance for contraindications and precautions for the vaccines. That was something that was requested at our last meeting, and it resulted in update 31. Update 32. If you go to update 31 on the vaccine information page, you'll also find that that gives the information that we're talking about for essentially registering and scheduling the vaccines. And at this point, we're still at the most risk individuals in 1A, and we may be talking more about that as we go forward. Last thing that we've had a number of calls and interactions with pharmacies and others who are interested in becoming an enrolled vaccine provider. And so on the site, or I can send you directly instructions and the application agreement that's available there, where you can go on and you can request to be a site. And this will be likely for the latter phases of the distribution, where you would be given an allocation and you would have to complete certain protocols to ensure its safe storage and its allocation according to state protocols. But that would include sites such as urgent care facilities, primary care practices, pharmacies, other locations across the state that can meet those requirements and were willing to distribute the vaccine to the general public. Again, the information on the is all on the COVID vaccine information site from the department. That URL is there. Next slide. I'll conclude. I just want to thank our sponsors for this alliance meeting. They've contributed to allow us to pull these together and to assist the department in bringing forward information and helping coordinate these activities as we move forward. I believe he should be on tonight. Brian, do you see T.W. Hall online yet?
Not as of yet, sir.
Okay. So I know Dr. Chan won't be able, he has a conflict for this particular meeting, and T.W. Hall, I'll briefly give you a little bit of an introduction for him. He is the public health officer in the New Hampshire Bureau of Infectious Disease Control. He is an RN by training and is currently working on his APRN or nurse practitioner degree as we speak. TW is leading, essentially coordinating the allocation process for the department, and hopefully he'll be on shortly. While we're waiting for TW, I will mention a couple of things that were gleaned from what we call the SDMAC meeting the other day, and that is New Hampshire's State Disaster Medical Advisory Committee. And it's used for really two purposes. First, it was used to help develop the state's critical standards of care. And secondly, we've been giving input on how to move the allocation process forward. So the department's reached out and has inquired. And that group is made of up about 25 stakeholders, including ethicists, epidemiologists, other key stakeholders across the state. That was appointed by the commissioner to help provide that input. That input is advisory. So the department takes back that information, and that helps them determine their specific guidances. And if you've seen on the website, the vaccine allocation plan is fairly generalized, and what you've seen and will see on the vaccine planning site is more specific guidance. So in part, they gave out very specific guidance and tiered information about the 1A cohort moving forward. We learned that they are actually drafting the technical assistance or the guidance for the 1B cohort. And they expect to roll that out in about 2 weeks. So we'll be moving through the rest of 1A probably in that time period, and it's estimated based on current supply that we'll be starting that, that guidance will be out in about 2 weeks, and then we're moving into a phase 1B of the allocation process. As noted in the national ACIP documents, that the phases and the tiers will begin to overlap a little bit, and certain sites, say our fixed state sites, may be operating at a different phase slightly than say our hospital sites, or perhaps even the enrolled provider sites. So just a little patience that this is not necessarily a tidy process, but we're trying to get as many through and administer vaccine to the supply which we're given in the state. For the breakdown of each of the phases, 1A includes about 110,000 individuals. 1B includes about 170 of those who would have medical comorbidities, about 100,000 that are age 75 and over, and about 15,000 that would be in other congregate settings other than long-term care facilities. As we move forward, the decision before the SDMAC, which was should the state keep its emphasis on trying to lessen the number of deaths, or should it focus on lessening the number of infections? And that in part impacts the allocation process. I think what I heard or gleaned from the discussion that was to keep the guidance or the plan as currently formulated to focus on lessening the numbers of deaths at this time. Is TW there, or are we still waiting for him to come on board? I guess we're still waiting for TW. We have some information on documents that we'll be sharing with you on updates in your chat function. At this time, we're happy to address some general questions before TW gets on the line as we move forward. And anything that we've discussed, anything currently that you're kind of wrestling with in moving forward. So if you can make those, you can type in your questions in the chat area, and we're happy to try to wrestle with, or get some information back to you there. Here's the first message. It says, I received my vaccine on 12/31 at Exeter High School. I was astonished at the level of professionalism and military precision that this process carried out. My vaccine was scheduled at 1:50 p.m. The nurse came out of the tent at that time, and I walked directly to my my vehicle. I was done before 1:51. And kudos to all who played a part in developing the rollout. I am proud to be part of the state that took this process extremely seriously. So thank you very much for that submission. And that's exactly what I've heard from some other states, that the turnaround time when you have a scheduled appointment is less than 20 minutes, often much less than that. So that process seems to be working very well at the fixed sites. And I think that's something to convey to your constituents as we move forward. It was asked if we can review the other phases going into 1B and 1C. Right. Let's talk about 1A first. The clinical frontline workers are part of 1A. The most risk include essentially dentists, emergency medical responders, technicians, paramedics, we have hearing aid specialists, hospice aides. We have, of course, physicians, pharmacists, pharmacy aides, nurse midwives, nurse anesthesiologists, nursing assistants, orderlies, and psychiatric aides, PAs, again, registered nurses, and some therapists. Some other non-clinical workers in that most risk category are clergy, counselors, personal care aides, community and social service managers and staff, passenger vehicle drivers, environmental service personnel, and security guards. Part of the moderate risk, and while we've only focused on the most risk, we know that some of the moderate risk category are already signing up. and requesting schedules. Moreover, we've heard from most non-hospital settings that they have been able to schedule those. Only a few that for some reason didn't get the message, but it's gone out through many different channels. But the moderate risk include acupuncturists, audiologists, chiropractors, clinical lab technologists and technicians, dental and ophthalmic laboratory technicians, diagnostic registered technologists and technicians, dietitians and nutritionists, massage therapists, opticians, dispensing, optometrists, physical therapists, assistants, aides, podiatrists, psychiatrists, social workers, barbers, hairdressers, stylists, and cosmetologists. In the retail section of moderate risk, it's food delivery personnel. In the food retail, it's cashiers, cooks, food preparation managers and staff, dishwashers, dining room and catering managers and staff, food service managers. Other non-clinical individuals who are in the lowest risk of 1A include childcare workers, couriers and messengers, dispatchers, drivers, sales workers, and truck drivers, ground maintenance workers, instructional coordinators, dry laundry and laundry workers, lawyers and other legal staff, librarians and medical collection specialists, mail clerks, mail machine operators, machine repair workers, medical scientists, parking enforcement officers, and then switchboard operators, including answering services. Again, we haven't quite got to those medical risk individuals at this time. All these lists are published under the what I have as the December 24th allocation guidelines for phase 1. So you can go in and read those. They also talk about that older adults in residential care settings. And this is part of the federal distribution plan that's being administered through CVS and Walmart. Walgreens. That is a separate program that the state is carefully monitoring. We've heard that that's had a couple bumps in the road, but that's proceeding. So that will be all staff and residents in long-term care facilities, skilled nursing and assisted living facilities in particular. In 1A are also fire and EMS, and that includes private, public, volunteer fire, emergency medical service personnel, law enforcement, and that is all certified and sworn enforcement officers, either full or part-time. At this time, it doesn't include those in correctional facilities, but I think there will be an update to that. Also, COVID-19 responders, so personnel with response to patient or SARS virus contact. This will include, again, testing lab technicians, specimen collection personnel. Is TW on at this time, or are we still?
Confirmed, yes, yes.
TW, thank you for joining us. The tap dance was getting a little thin here. But again, welcome. Thank you for joining us. We talked a little bit, recapped some of the things from last week, and recapped some of the discussions that were held at the SDMAC about the technical assistance for 1B. So as we always do, could you kind of give us an update of where the state allocation plan is at? And any challenges you're seeing right now and how we're moving, and then what are your next kind of anticipated steps for the other categories of 1A as well as those in 1B and 1C?
So good afternoon, everyone. I apologize for my tardiness. I had a couple of things come up and was unfortunately delayed, but I do truly apologize because I know all of you are extremely busy. So let's see here to put the information as Jim was saying. Let's talk about first allocation. So when we're talking about allocation and where we're at right now, um, what we currently have in place is we have allocated the last amount of our state required vaccine to our long-term care facility program. So that's the PPP program that Jim was referring to. That's the pharmacy partnership program, which is CVS and Walgreens, and how they're going into vaccinating long-term care facilities. So they now have the doses to do that good work that they're doing. And so that means that we then, now that we've fulfilled the requirements, if you will, as well as the things that CDC and Operation Warp Speed have put in place to be able to allow that program to move forward, we're now getting more doses brought into the state for other efforts, which are the rest of the people in 1A, which are most risk category of hospital workers, our most risk category of ambulatory care workers. We currently have a survey out to the hospitals to kind of see where they're at in terms of those areas. On our fixed sites, we've been working through some challenges with the VAMS application, which is the Operation Warp Speed application that basically goes through its schedules. We've gotten some preliminary data back that even when we're sending out invites, people's appointments are getting canceled at different times, but we're not quite sure what the percentage of that uptake is. So we're looking into that problem currently right now. Overall, we have a lower percentage of people that have signed up than have, or we have sent out requests to allow people to sign up. And of those people that we've sent out requests to, we have a lower percentage. I think it's about 80, 70 or 80% that have actually signed up. So that means that we've obviously got something going on with our system, which is kind of what led us to this in the first place. And so now we're trying to define and figure out what the system is. As I'm sure all of you can appreciate from working with EHRs that aren't necessarily your own design or you have your own control over, we're working with the experts to try and figure out what's going on and then put systems in place to make sure that we're pushing through and regardless of what's going on with our technology, we can get people vaccinated and signed up. So we're working through that on the fixed sites. We're also taking a look at where we're at in the response. As I'm sure many of you heard before, the old saying that no plan survives first contact. You know, when we're a couple weeks into this, we take a look at our theoretical models of what we've done and what we've tried to plan for and our fairness and our equity and all these different areas. And we say, okay, so now that we've gotten some practical experience under our belt, what are our lessons learned? What are some of our response rates? What are our vaccine hesitancy? Where do we need to focus on education? Where do we need to focus on throughput to make sure that we're not sitting on doses anywhere or any of those areas? Because we know that this is a very limited quantity. And so we want to try and push this through and make sure that everyone is receiving it. So you always have the two balances, right? You have equity and making sure that we're doing our best to try and meet those tenets and allow people to get vaccinated regardless of what their throughput is, so to speak, you know, whether or not that's 20 people a week or 40 people a week, and having enough doses on hand so that's fair across the state of New Hampshire. And at the same time, wanting to make sure that, you know, let's say that, you know, I'll throw my name out there, but TW's hospital is only going at this rate, or you know, this group is only going at this rate, then we want to make sure that there's enough doses for them, but also we're not over allocating to them so that we couldn't use those doses in another sector and still make sure that they have their fair quantity when they're ready for it. So there's a lot of different things to move through and try and figure out in terms of that. So we're working through this week to look at those and make sure that we've got a good understanding of what our throughput is out with our hospital organizations and things that they're doing, as well as looking at our own systems of our mobile and fixed sites to figure out what we can do to improve those areas as well. So it's a learning experience for us all. And so I appreciate you guys being patient with us, and know that we're doing our best to try and work through some of those challenges, and just trying to be transparent with you all in terms of what some of those challenges are and how we're trying to address those and fix those. Jim, you had asked me to then talk about next steps, if I caught that right. And so my guess is, depending on what our actual vaccination uptake is, assuming that it's in around the 80% range, which depending on the group, we've seen some anecdotal numbers back so far that are looking at the 90% range when it comes to healthcare workers, but then maybe the 50% range when you deal with law enforcement or something like that. So we're trying to take those anecdotes and really kind of get the data behind them and see kind of where we're at to do that. But as we look at that, our next group, right, as we're working through these and figuring out where to go to moderate health workers and make sure that that's ready to go and have all those people signed up, as well as maximizing our own throughput with our mobile clinics and our fixed sites. Then we look at, okay, when we switch to 1B, first of all, what is 1B? So we're working through that with senior leadership at the state level to get those finalized. And then as we do that, we will change our focus of our response to then being really that provider patient level group. And I anticipate that coming probably in the next, I would say, 3 weeks. Third week of January to last week of January is probably my best guess right now based on different areas. So as we do that, if you are a provider that is interested in being a purveyor of vaccines, so to speak, then please make sure that you're filling out your provider agreements and getting those put in, because if we don't have those in shortly, then you won't be able to get those allocations as they become available to provide those to your patients. As backups to provider agreements, we also have conversations and things that we're working out through CVS, Walgreens, and some of the other pharmacies to try and allow for vaccine allocation in those groups, as well as our own public health side, where we're looking at the fixed sites and things like that. The next couple of weeks, I'll be perfectly honest with you, we got quite a few challenges to overcome in terms of making sure that we're doing this in a manner that is fair and equitable, but also understanding that when we get down to the exact methodology that we've used in 1A, we're going to need to tweak that a little bit, because we don't have we have estimates of denominators of, let's say, 2 or more comorbidities throughout the state. But those estimates aren't nearly as strong as maybe some of the things that we've used for 1A in terms of those solid numbers that we have of how many healthcare providers we have in the state, how many first responders we have in the state, and things like that. So working through all of that and making sure that we're ready to flip that switch once it comes and goes from there. The last message that I'd probably say in terms of general updates is that if you have sent out an invitation to or are considering getting vaccinated and haven't filled out a form yet or whatnot, please encourage your counterparts in the medical community to please do that. Because we'll be looking at wrapping up those appointments as much as we can over the next couple of weeks, so that we can then move to vaccinating parts of the general population. So, Jim, was there anything else in specific?
That's great. No, thank you. Spot on. So just a couple of questions that I know came out of the SDMAC conversation. So when do you think you'll begin to use the enrolled vaccine providers? Is that part of 1B, or do you think it'll shift further back to 2?
Yeah, no, I think that is a part of 1B, because we are looking at, again, in every response, you kind of look at how you manage your general population and those most at risk in the general population for not only your morbidity and mortality, but some of the other essential pillars that we have in that category, along with your essential workforce, right? So you're balancing out your general population, your essential workforce, and in each of the phases. And from the preliminary things that I've seen, I think we're going to have a strong emphasis on that general population as a part of as a part of 1B. So certainly look to finalizing your provider agreements if you haven't done so already, and getting those submitted so that we can do that. Now, I'll be perfectly frank with you. If our allocations are still at the level that they are, for example, we got 8,400 doses that we had available to us this last week that was not a part of the long-term care facility program, then it's going to take us a little while to get through things. So just because you signed up with a provider agreement might mean that, as we're trying to figure out where doses go and everything else, it might be in drips and drabs initially, depending on what our allocations are. And so just please be patient with us, and we'll try and work through a good methodology to distribute that.
That's great. And how will those either those enrolled providers, how will they find out, or how will you communicate to them? And what's the kind of the next steps after they've signed their agreement?
So I think there's several things that we want to have come together, and so let me talk about those different points, and they're all points that we're working through in the next couple of weeks. Number one, we want a system that as much as we can work through and gives you a couple of options in terms of documentation. And so we're working through what that looks like and whether or not how we leverage that to make sure that you're set up. But right, we want to make sure that documentation methodology is in place and that you have training for that. Two, we want to make sure that as we go through and your provider agreement signed up and you're comfortable with that technology and things are set up, then that your clinical questions and things like that, the things that you are comfortable with in terms of sending out, that you're all good in terms of feeling comfortable with the questions that are going to come into you and whatnot. Then I think comes the next part, which is that strategy part of going, okay, so how are we going to do this, TW? We've got 8,000 doses. We got 600 providers. How are we going to distribute that in a fair and equitable manner? And that's what we're finishing out in terms of our strategy for this next group. And that's what then we'll convey out to you in terms of how then you order what we do. Is that a cap, for each group? Is that based off of a percentage of the size of your practice? Is that, how do we balance out medical homes and non-medical homes, people that don't have medical homes and things like that. So those are all things that we're currently working through to get that final part of that strategy piece to say, look, here's exactly how it's going to go. Boom, 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 boom. Here's what we need you to do. Here's what we need you to say, go through in X, Y, and Z. One of the things that I can say definitively out of the strategy is that unless something changes drastically with our allocation, that all of us will be wanting a lot more vaccine than we'll actually be getting. So just be prepared for limited doses coming in. So as I put myself in your shoes as much as I can, that then goes to yourselves going through and taking a list as soon as the 1B categories come out and trying to stride in your population who are your most at risk of the groups and categories that we are recommending that you go through. And so as soon as that guidance goes out, if you can take that guidance and then work through your electronic health records or your written records and try and start to comb through and figure out who those groups are so that you can say, okay, if I have 20 doses, here's the group that I want to send out an invite to for those 20 doses because they're that most at risk. They're the ones that ideally I'd like to get vaccinated first. That type of setting.
That's great. So yeah, two related questions to that, just on the vaccine providers. We've been approached by some major employers in the state who are also interested in becoming vaccine distribution sites. So do they follow the same process as making the application, following instructions and making the application of the agreement, the provider agreement? Is that the first step? And what kind of other considerations, if they agree to be a vaccine distribution site, would that be to the public? Or is that or could it be restricted? Is the expectation that it'll be to the public in general, or could that be restricted to their employees? So there's just a discussion that.
So let me, and I apologize because I want to make sure that I'm capturing the right way that I'm interpreting that question. So if I understand correctly, there are organizations that would like to be major distribution hubs of vaccine. And when we're talking about that, and we're talking about a hospital network, we're already gaming those types of things out and working with them on what their hub and spoke model looks like, so to speak, and how that looks and how we can keep vaccines safe and at the right temperatures and all that sort of stuff, but get the vaccine to where it needs to go in that organization. If you're talking about like a third party group, so like an Ingenesis contract or something like that, where there's private groups that are looking at coming around that are looking at basically subcontracting with you to do some sort of work. I'm not quite sure if that's the vein that you're going in.
I think it's in particular, it's some larger employers who already have a clinical staff, already have and are willing to kind of staff up and agree to the terms for appropriate storage and administration. So it's essentially a large employer who says we'd be happy to be a vaccine distribution site. And so the questions are there limitations to that, or are there expectations that if they do something like that, that it would have to be also offered to the general public?
Thank you. So a couple of different standpoints on that. So the first is that absolutely, I recognize that not everyone has the capability or the bandwidth to be a provider of vaccine, right? And so if I had a small private clinic and I had a few hundred population base, and I had someone else that said, hey, look, I'm TW, if you talk with me, I'm willing to do that for you. Just send your patients towards me in whatever way. I don't want to dissuade that, because I think that's a most reasonable way to go, and we want to make sure that we support you in that. We also want to make sure that we're accounting for when you do that, what that looks like, so that person then gets some sort of striation of your list. Because if I was their provider, right, I'd want to make sure that, okay, yes, I'm sending over my list, but I'd kind of like to categorize for my patients where they should be in terms of a hierarchy, so to speak, or whatnot. So I would encourage you to kind of think in those lines for that. When we deal with vaccination and getting to the public portion, I would say that the more that we can provide vaccine in different ways increases our equity. And so, is that a requirement for a vaccine agreement? No, it's not. And we all know that there's some good health reasons why you want to vaccinate only your patient population. So I don't want to discourage that or come across like that, because I recognize that also gets them in to establish care and check blood pressure and go through all these other things that we want to do as providers, and make sure that they're all set up to do that. At the same time, I also ask that if you have the flexibility to open up for the general population, I don't want to dissuade you from that either, because again, in a goal of a pandemic, it's to try to decrease our barriers to different populations that are trying to get through. We know a certain population doesn't have a medical home. We know different groups are trying to do what they can to increase our equitable distribution. And so I don't want to dissuade you of that either. So really it comes down to having conversations, checking out bandwidth, seeing what you're able to do for not only your patients, but the general area, and taking your individual, temperature, if you will, on where you're at and what you can do on that.
Terrific, thank you. Last question related to that, is the expectation with the 1B phase to shift from VAMS to the New Hampshire Immunization Information System, or would that be later?
Thank you for that. So as you can tell, we've had some challenges with VAMS. And So what we've done is a few months back, we've established a contract for an external system that is VAMS-like in terms of what it has the capability of doing. So that's scheduling, that's reminder recall, that's that type of stuff, because we want that. Number one, we need that for the public side, right? Because we don't have a public EHR. We don't have that is our electronic health record for this response for the public side. So no matter what the non-government side of the response does, we still need that. Then we need a centralized way to make sure that we're getting that data in there. And for those of you who have used IISs in other states, you recognize that that's great for HL7 or when we do, big batch uploads or things like that, but it's very hard to go through and have a mass clinic and direct data entry for each patient as you go through. You're adding 5 to 6 minutes for your vaccination time, and that can really cut into what your capabilities are to hold a clinic. So what we're trying to do is we're trying to use the IIS as the backbone to store this so that we can do things like query that data and make sure that we're not having duplicates and make sure that there's a good database that's kind of behind the scenes to make that work. And at the same time, recognize that an IIS is not designed for a mass vaccination clinic. So whether or not you have an EHR that has a module that can do that, we're trying to figure out how we can give you the options to either leverage that, or if you don't have a good basis for your EHR to work through, to then do a separate system. And that separate system being paid for by us so that it doesn't create a fiscal burden on you all. So those are some of the different pathways that we're looking at, and we're getting more guidance out in terms of what that looks like. We do not have the ability to create, for those of you who are more tech savvy, an HL7 message. We eventually, our IIS will have that, but it takes a couple months for that to be built up with each provider. And so trying to say that we're going to do that while we're doing the pandemic and everything else is unfortunately something that's a bit of a pipe dream for those of us in immunization. We'd love to do it, but I don't think we have the bandwidth to. So we got to try and figure out, okay, do we go back to an older technology where we do a flat file upload or things like that, where that's how you get the information from your EHR into the IIS, in which case you would just document in your electronic health record. And then we would tell you a certain format of comma delineated or Excel file or whatnot. And you would print that list out and then upload it into the IIS. And what's that look like, in terms of bandwidth and challenges and things like that. So those are those options, but then we also want to have an option for those of you who either don't have that capability with your EHR or don't have a scheduling component that's really great or a reminder recall and would like to leverage a system like that. The bottom line is that no matter how we go about documenting, we need to make sure that we are capturing the data that you guys are inputting so that we can, again, have a statewide amount of response that we can have an eye on, and we can make sure that works out, because we do have people getting their first dose over here and their second dose over there and other things that are really hard to work with the systems that we have. And so thank goodness we're a small state, and we'll work through those challenges as they come up.
Great, thank you. Let's dive into some of the questions that we received. What I've heard is most frontline staff in Wenny who have gone through VAMS, usually once they pre-register, they get an invitation within 24 hours. What happens, and we've heard this in a number of cases, where a specific practitioner doesn't get anything back for a number of days? Should they go back in and pre-register again with the system?
No, so thank you for that. So the first thing that I would say is that immediately when you fill out your online form, so that's that blog form that we put out, that we put in the chat last week for filling out that online form. When you fill out that online form, you should get an immediate email response. If you did not get an immediate email response, that means that either there was a typo or something like that in terms of that email that you registered with, it went to the wrong, something happened with that. So if you don't get that immediate email response, then what I need you to do is reach out to the group doing the scheduling, and I believe on the HAN, and Jim, I apologize, I don't have it in front of me, but I believe that in HON 31, there is a listing of contacts that we tried to put in there to make sure that you had where to go for what. That's when I would reach out to through that email or through that capability to say, look, I registered, here's my basic info, and I haven't received that email response. Now let's take it one step further. You got the initial email response, but you still haven't heard anything back yet. Right now, my understanding is that our turnaround's around 5 days or so. So if 5 days have gone past and you still have not received an invitation, then I would have you go through that same mechanism of reaching out through what we said in the HON in terms of that notification system, so that you can say, hey, look, so just checking in to see what happened. And then we want that feedback, because if for some reason you're not getting registered and that's a large portion, or we have a bug in VAMS that we're not aware of, we want to make sure that we hop on that right away and make sure that we get that taken care of.
Great, thank you. There's a comment that there's a frustration from some patients wondering when the vaccine will be available to the general public.
Mm-hmm.
I just want to reiterate that actually phase 1B is focusing on about 300,000 individuals with, one, either have medical comorbidities, two, that are 75 years of age or older, or three, live in congregate settings. So I think when that guidance for 1B comes out in 2 to 3 weeks, that will be the focus for essentially the first phase of kind of the general public for those high-risk individuals in the general public. Is that correct?
That is correct, and hopefully it'll be sooner than that 2-week mark, because again, we want to try and get this out and finalized as quickly as we can. And so we're please know that we're burning the midnight oil, so to speak, to try and get through it as quickly as we can, get those up and vetted through senior leadership at the state, and then back out so we can get you all that guidance. I completely understand the frustration. I've come across it myself, and I recognize that. And the only positive I guess I can say out of that is I'm excited that people want to get the vaccine. That's great. And I recognize that it's not happening fast enough for many of us. And so we're doing everything that we can to try and speed that up and communicate clearly where we're at, what we're doing, why we're doing it. So even if you don't necessarily agree with the logic, you can at least see that there is logic there, and what we're trying to do to accomplish that.
Great, thanks, TW. The next question has to do with 1A. So there's specific guidance on most risk individuals in phase 1A. Will there be other guidance coming forward for the moderate and low risk individuals in 1A? When should we expect seeing that?
Yes, and I anticipate, honestly, starting to put something out at the latest would probably be next week with that, or it could be as early as this week. Again, what we're trying to do is we're trying to see, okay, we've got, and again, this is theoretical versus practical, as I like to put it, right? We've got a theory of, we've got 100,000 people that we're trying to get through in 1A, and we've gotten to about 60,000 of them, let's say. Okay, so where are we at? Have we covered of that 60,000, the majority of the most risk population? So now it's time to open it up to the moderate. And we want to do that in a cadence that doesn't allow for slowing down. The other aspect of that I just want to be clear on is that you also don't want to start in one portion of the state where you're going to have a little bit of this, where one part of the state might start with moderate and another group or organization might not be there yet. A little bit of that is okay, right? But a lot of that is not okay. So it's understanding where that threshold is to make sure that when we flip that switch, we don't have 60,000 most risk hospital workers or whatnot that are still waiting to be vaccinated, and we turn it on for moderate risk. So it's, again, trying to get back what we've gotten in terms of feedback in terms of vaccine hesitancy and things like that, to make sure that the people in those most risk categories have been offered a vaccine. And if we know that they've been offered and we got up, let's say that we got up to 80%, which is one of the recommendations from CDC of when you start to switch from one phase to the next, we have over 80% of people in the most risk category have been able to be offered a vaccine and start to get put into the pipe. Then we can start to look at moving to the next group. And we want to do that, again, as quickly as we can so that we're not slowing down the process.
Great. Thank you. Next question just has to do with publicizing or publishing rates of immunization.
Mm.
And so can you let us know how often do you think that data will be published to the public on a weekly, a daily basis? If so, how stratified will that be? Will be to specific professional categories or within the sub tiers, or how is that information likely to come forward?
That's a great question, and I apologize. I don't know the whole answer of that because I don't. Part of that depends on specifically what we're requiring in VAMs to be filled out, and then of what we require in VAMs to be filled out, then how we look at our denominator, right, in terms of what that looks like in vaccine hesitancy. So I apologize. I don't have a better answer for you for that, but I know that we are looking at trying to get as much data as we can to be as transparent as we can. I think we're also just looking at which areas we're collecting and trying to, it's always the balance of practicing versus also being transparent in terms of your data. How many data fields do you require? How many areas do you go through to do what you can to get that good information out, but at the same time and stratify it in a certain way, but also not slow down your response and have people fill out multiple fields. So it's a balance there.
Right. The next question is, and I guess this is talking about community health centers, who would be that next phase of your vaccine providers who've signed agreements. Can they distribute the vaccines to their at-risk staff? And is the difference that those distribution quantities won't be available until at least phase 1B?
Thank you. So, two things out of that. Number one, we have the people that we have assigned as providers to allow for people getting vaccinated in 1A. We have that established, and we're working towards the tail end of that, right? So now we're looking at 1B and making sure that we're set up to do that. To what that means to operationalize that is that those workers in 1A category, let's say that I'm running an FQHC and I've got 25% of my staff that says, yeah, I want it, but I don't want to be the first one to get it. I want to wait a month and then I want to get it, type of thing. When we're in 1B, you can certainly vaccinate those categories that have come ahead of time with what you have, because you are a provider of that vaccine at that point for your patients. The challenge is that as we move through and what those allocations are also comes with limitations, right? So if we're getting 8,400 doses in each week, and that's what we have to play with, and we're pushing that out for patients, and that means that, TW's clinic gets 20 doses and I've got 7 staff that want to take it. Absolutely. They were prioritized for a reason in terms of trying to get it. That also means that I got 13 less doses to offer it at that time to my patients. So it's just kind of working through that and understanding that it's going to happen, and that's the way of it. And we want to make sure that everyone gets vaccinated, but just understand that I don't have a magical way of coming up and giving you 7 more doses at that point to take care of those health workers. So there's a period of time, so to speak, in which you're trying to get vaccinated and we're trying to account for that vaccination. And then as we move on, those doses, if no one's stepping forward and saying, yeah, I want them, we don't want to just sit on them because that's not good. We want to then move forward with that and make sure that we're using those doses appropriately, which means that then moving on to offer it. So can people in a higher category be vaccinated? Always. But it goes to then flow of your vaccine and what you have available at that time of when they choose to do that.
Terrific. I just want to do a time check. It's 1 o'clock. Do you have another 5 minutes to answer questions, or do you have to wait?
Yes, I can definitely do that, since I apologize and I was here late to begin with. So my apologies.
There's been a couple of questions on the use of mobile vans, other mobile kind of distribution sites. Mm-hmm. And so the question is, do you anticipate using those for particular subpopulations within phase 1B? And the example was individuals with developmental disabilities, including autism. So getting them to a fixed site might be more of a challenge.
Yeah.
If they're going to do that, who would they try to work with? Is it their local public health office or area agency? How would they try to to work on kind of that scenario?
Thank you for that. So yes, I think that there are a wide variety of different smaller populations that for whatever reason can't reach a fixed site, can't reach a provider, are homebound, are lots of different areas. So let me just talk about that strategy just for one sec. First, if there's a non-government entity that is already taking care of their medical care and things like that, and going into that population, and I'm thinking of like VNA, things like that, we want to set up a provider agreement with them directly so that we can get vaccine to them so that they can tap into their already existing network and move through with that. So that's the first thing that I would say. Second thing that I'd say out of that is there's times where that doesn't happen. There's times where you get into some congregate living settings like those that have autism and some of the other cognitive development challenges. And when we're in that, that's where then we tap into our mobile clinics, and those are the regional public health networks. So that's who those groups would reach out to try and set up a mobile clinic with them at that appropriate time. And we're doing our best to try and use those mobile clinics as much as we can with each layer of the response for those that well, I want to put this right, truly have a need or truly have, it's not like we're sitting here measuring, but again, doing our best to try and figure out all the different ways to come together to do that. Because if we all relied on mobile clinics to go around, and we did it for not only those that are experiencing autism, but we also did it for people that might be able to get to the fixed sites or the provider as well, then that takes away from that resource as well. So we're just trying to ask that everyone kind of be good stewards about thinking through that and definitely going through. We also want to set up the regional public health networks for equity and fairness. And so that's our primary mechanism to do that because they are mobile. They can go into a setting and work with that, whether or not it's congregate living settings of elderly, or whether or not it's those with developmental disabilities and other medical comorbidities, or whatever that is. As that guidance comes out, that's our tool to do that on the public health side.
Great. What kind of documentation is going to be required for those individuals in 1B to somehow, I guess, verify that they have a comorbidity beyond the age?
A good question. I think in order to answer that, I gotta get a better handle on specifically where we're going to be with that. And I think that as we come down with that guidance from senior leadership and whatnot, that'll become a little bit more transparent. But for right now, I apologize. We're going to have to stand by and wait on that one.
That's great. I think that's it for the questions that we received in general. I want to respect your time. Thank you, TW. We did have some questions that came on that asked about PSAs and communications plan and whatnot. I think what we'll plan to do as we're ramping up to 1B in the next couple of weeks, we'll probably invite some of the communications team from the division to come on and describe the state's communications plan, what they're undergoing, and how other stakeholders can contribute to that effort as we move forward. So we'll stay on, try to stay on for a little bit and answer any additional questions that you may have. Again, TW, thank you for your time this week, and we appreciate everyone for attending. If you have any questions after this, please don't hesitate to email me directly. It's james.potter@nhms.org. We do a lot of it usually after the hour afterward, and I'm happy to follow up with you in specific if you have any individual problems or anything else going as we move forward. So that email address was just put up in the chat box. Again, thanks TW for your time. We look forward to seeing you next week. Thank you, everybody. Take care.
Thank you for all that you do. Truly appreciate you guys.